Hi, I'm Tom Buchholz. I'm a radiation oncologist who practices at Scripps MD Anderson Cancer Center in San Diego. I'm also the medical director of Scripps MD Anderson Cancer Program. So the term high tangents is sometimes thrown around breast cancer conferences, and you might hear it in a tumor board setting. But it actually describes as a technique that is aimed at treating the low axilla, meaning the level 1-2 axilla, during the same fields that are used to treat the breast. So the breast, typically following a breast conservative treatment, is treated with two opposed X-ray beams that glance across the chest. If you think of a CAT scan and think of it almost like a circle, the contour of the external nanobeam being a circle, if you remember the geometry term of tangents, it's kind of skimming across the circle per se. And so when you look at the orientation of the radiation beams used to treat the breast, they approach it in a tangential plane to minimize the dose undergoing to the undergoing lung and normal structures of the thorax. So typically we treat the breast with a medial and a lateral opposed tangential beams that safely exclude the majority of the intrathoracic contents. Just a very small amount of lung is treated and the heart is excluded from the field. Now, when you design the fields, because the apex of the breast extends into the low axilla and the level 1 axilla really is in continuity with the apex of the breast, we've always treated this region in the radiation fields just as a bystander. We never really thought about it, however, because historically in the era of axillary lymph node dissection, this was not felt to be at risk of having disease because that lymph node region was adequately removed with an anatomical dissection. Nowadays, we encounter situations where we want to treat lymph nodes in the low axilla because most commonly the situation would be that someone was found to have a positive sentinel lymph node after a breast conservative surgery and elect with their surgeon, and me as a radiation oncologist would endorse this too, not to do a completion axillary dissection. So in that setting, as you know, there have been randomized trials comparing completion axillary dissection versus not. The ACOSOG Z11 study was perhaps the most widely quoted one here in the United States, which showed equivalent outcome whether or not you did this completion dissection. We also knew in that study, if you had a completion dissection, you had a 24% chance of having an additional positive lymph node, which wasn't a particular surprise because as sentinel lymph nodes were first employed in the United States, they were always done in concert with a completion axillary dissection. And typically you would find anywhere from 20 to 35 to even 40% chance of having additional axillary disease if you had a positive sentinel lymph node. So the data from Z11 in those who had an axillary dissection was quite consistent with the previous described rates of additional positive lymph nodes. Well, one would wonder why then, if you didn't have a completion dissection, why weren't you seeing 25% of the people have recurrences in the axilla? And one of the potential explanation was that the radiation fields treating the breast actually treated the remaining lymph nodes. And indeed, now with modern techniques, you could actually visualize in 3 dimension using CT treatment planning where these lymph nodes sit in relationship to the beam. And you could actually design the beam such that it's not a happenstance that you're treating these lymph nodes, but you're actually directing the beam to treat those lymph nodes. So the move from tangent fields to treat the breast to high tangent fields is just a description where sometimes we increase the length of the field. And it's probably more important not to talk about techniques in tumor board, but to talk about targets, because we should be thinking about what are we treating with radiation. So rather than say, I'm going to treat this patient with high tangents, you should say, I'm going to treat the breast and the level 1-2 axilla as my target. And then you could design the fields with 3-dimensional structures to assure that the target is included and receives adequate dose within the field. Before we had CT treatment planning, I'm kind of dating myself here, there were anatomical landmarks that we used to use for high tangent radiation techniques. Of course, now we can simply contour things out on the CT treatment planning scan and we could actually see the three-dimensional structure of the axilla and calculate the dose so that we get it there. So when do I use this high tangent technique per se? Or more importantly, when do I target the low axilla in addition to the breast? With those common situations where people have breast conservative surgery, they have very favorable disease characteristics, and I want to cover the lymph nodes that are residual following their surgery. And again, when you didn't have a completion dissection, the most important lymph node targets would be the level 1-2 axilla. Now, in different situations, say someone with a very aggressive cancer came in and are found to have multiple positive lymph nodes, or found to have positive lymph nodes even after neoadjuvant chemotherapy before their surgery. In those instances, then I think clearly we have to target level 1-2 axilla if that wasn't removed surgically, but we also have to target additional lymph nodes, namely the level 3 axilla, the supraclavicular fossa, and the internal mammary. And those fields are sometimes called regional lymph node radiation fields. They're going to include additional fields beyond the tangent fields that are geometrically matched, and again, additional contouring. So rather than describe the fields, I think we should get in the habit of describing our targets and then designing the fields to hit our targets.